So I'm delighted that we're keeping the trains running on time here. I'm also delighted to introduce our next speaker, Dr. Teresa Magone. She's a highly specialized ophthalmologist, also down at the NIH. She has fellowship training in corneal diseases, but also in ocular immunology. And Dr. Magone has held the position of chief of the consult service at the National Eye Institute since 2019. And in that role, she supports ophthalmology care for many, many patients, and actually over the implementation of over 140 active clinical protocols. Within the NIH community, Dr. Magone is also a member of the chronic graft versus host disease group that's led by Steve. And in that context, she's involved in the care of BMT patients, both pre and post-transplant. The title of her talk today will be Systemic Treatment with the Janus Kinase Inhibitor, Baricitinib, for ocular chronic graft versus host disease. Dr. Magone?
Thank you for the kind introduction and for the invitation to speak here. I'm honored. Yes, I do work with Steve's group and all the transplant teams at NIH, and we try to manage optimally patients with ocular graft versus host disease that are enrolled on clinical trials. And Steve recently completed a trial, phase 1/2 trial on Baricitinib for a steroid refractory GVHD, a chronic GVHD, and I will present just the ophthalmic data from that trial. Let me just see. I'm not pressing the correct button, or it's not advancing. Oh, the other, thank you. So the green button, I'm assuming. Okay, I have no conflicts of interest. In the first part of my talk, I will focus and review the pathophysiology of ocular GVHD from a clinical perspective, because I believe it will be easier to understand the eye data with that in mind. And I love that I'm following the fibrosis talk to Dr. Sinar, because a lot of ocular GVHD includes fibrosis. I already mentioned that I work with many institutes and we evaluate patients for toxicity screenings and also pre and post transplants. Just to give you an idea, we see, on average, 200 patients just with ocular GVHD a year. And in the last 2 years, we diagnosed about 102 patients with ocular GVHD. So patients with ocular GVHD complain about eye symptoms such as dryness, foreign body sensation, and light sensitivity. But in reality, the ocular involvement also affects every aspect of the patient's life. And you can see here in this study by Sabu and colleagues, they evaluated 83 patients with ocular GVHD and performed a visual function questionnaire. And you can see in the represented in the purple bars, the ocular GVHD patients reported scores, lower scores on all subscales with the exception of color vision. And this suggests that ocular discomfort, the experience is not just ocular, but it affects the whole activities of daily life. And so patients with ocular GVHD most commonly have the symptom of dry eye or the diagnosis of dry eye disease. But dry eye is not just a dysfunction of the lacrimal gland with decreased tear production. It is really the cumulative effect of the pathological changes of all structures of the ocular surface. And so what is the ocular surface? It is essentially a complex dynamic system that ensures optimal vision and visual function and protects the eye from infection and the environment. And in 2017, it was defined as a singular entity encompassing the structures of the eye and the adnexa, with inflammation within these components being closely interlinked. And so what are the structures of the ocular surface? They are the conjunctiva. Is there a pointer? This is a pointer. Oh yeah, I don't know if you can see the pointer. Yeah, it's right here. Okay, the conjunctiva, which covers the eyeball and lines the inside of the upper and lower lid. The conjunctiva also includes the accessory lacrimal glands, which also produce tears, and the goblet cells, which produce mucin to the tear film. Then the cornea, which is a clear part of the eye, and the meibomian glands, which produce lipid to the tear film and are in the lid margin. And of course, the lacrimal gland, which produces the aqueous tears to the tear film. And so the tear film is essentially a composite of all these and provides growth factors and nutrition to the cornea, to the ocular surface. And so in ocular GVHD patients, all these, which can occur in up to 90% of patients with systemic GVHD, you can see severe inflammation, often fibrosis in all of these structures with loss of function. All right. So ocular GVHD is characterized by a dysregulated immune response where alloreactive immune cells target host tissues and infiltrate. And for example, in the lacrimal gland, they can infiltrate the lacrimal donor cells infiltrate the lacrimal gland and cause fibroblast activation, fibrosis of the dactyls, and obstruction leading to decreased tear function. In the conjunctiva, 50% of the resident of the cells found in patients with ocular GVHD are also donor lymphocytes. And then in addition, there are macrophages and neutrophils. There is cytokine and chemokine upregulation and eventually tissue fibrosis. And the meibomian glands similarly have infiltration and then keratinization, which decreases the lipid content to the tear film. So we test the tear film production in patients with the Schirmer's test, where we apply a little strip to the lower lid and measure the millimeter migration of moisture after 5 minutes. This is a photo of my wonderful colleague and the other ophthalmologist on the consult service, Dr. Krieger, who is always willing to be my model. And so the tear gland also produces many growth factors, immunoglobulins, and also matrix metalloproteinase 9, which has a role in remodeling and wound healing of the ocular surface and the cornea, but also plays a role in inflammatory disease and is known to be elevated in patients with ocular GVHD. A Schirmer's test of 10 is normal, 10 or more, and less than 5 millimeter migration is considered severe dryness. We also evaluate conjunctival redness based on the scale by the International Ocular GVHD Consensus Group, which tries to evaluate more by objective measures and including also a subjective questionnaire. So the human conjunctiva is a mucosal surface and has the conjunctival associated lymphoid tissue, and it's located mostly in the superior palpebral conjunctiva, which I'm going to just point out up here. So the lid is flipped, and if you look on the inside, and in this paper by Reynoso, you see the distribution of intraepithelial immune cells in the conjunctiva, and he collected cells from 63 healthy donors and analyzed those with flow cytometry according to the topographic area where they were collected. And you can see in the image that the distribution differs between the upper lid and the lower lid, the tarsal conjunctiva. There are more CD8 cells, T cells in superiorly And inferiorly, there are more B cells. I can try to show it here. So the white bars is the upper tarsal, and then the B cells are in the lower part. So let's go to the clinic and look at some patients. So on the right side, you see a normal patient. This is also a colleague of mine who volunteered. And so the lid is flipped and you can see there is no inflammation. I know the lights are shining against the screen, but you can see the vessel plexus of the palpebral conjunctiva. And you can also see that my meibomian glands are each, you can see them, they're open. And then on the left side here, you can see inflamed conjunctiva from a patient with ocular GVHD. You can barely see the vessel outlines maybe here. And also the bulbar conjunctiva seems to be swollen. And you can, don't be fooled by this reflex. These are just refreshed tears that our photographers put in to make it more comfortable for the patient. But in reality, this is really dry. And so in addition to having T cells infiltrating the palpebral conjunctiva, there are also neutrophils that infiltrate the conjunctiva, and that has been associated with fibrosis and chronic inflammation. So in this graph that I'm showing here from Dr. Young-Su's paper, she performed impression cytology on 76 patients with systemic chronic GVHD without ocular GVHD, and she found more neutrophils again on the superior palpebral conjunctiva. So Dr. Jane from the University of Chicago showed also increased neutrophils in ocular washings of patients with ocular GVHD compared to controls. And this is important because sometimes in ocular GVHD, we see this mucus discharge. Our patients complain about this mucus discharge. And that's actually extracellular DNA from neutrophils, which is a normal part of the ocular surface. But those DNA traps or neutrophil extracellular traps, which are supposed to trap pathogens to help get rid of them, they are increased in these patients, and then that can cause ocular surface damage and inflammation as well. And so Dr. Jane recently published the results of a phase 1/2 trial where he used DNase drops, 0.1%, 4 times a day to try to reduce these nets in patients with ocular GVHD, and he saw a significant reduction of symptoms and corneal staining after 4 weeks. And in patients with ocular GVHD, they can also have a severe inflammatory reaction with membranes. And these membranes are sometimes very adherent to the palpebral conjunctiva. They were first described in 1983 by Hurst and were associated with higher mortality of patients. Once these membranes resolve, they often leave scar tissue behind. If they are not recognized and not treated aggressively, it can really increase scar tissue formation. And so if you look at the pathology of those membranes in a nice paper by Dr. Hayashi, you can see that there are macrophages predominantly, then fibroblastic cells, and also CD4 and CD8 T cells. And so here's a patient who had a membrane and it resolved, and you can see where the white arrows are outlining that scar tissue, and this not only makes the ocular surface irregular, but also decreases the function of the conjunctiva because there's loss of goblet cells, with that less mucin to the tear film, and the accessory lacrimal glands also are reduced, and so the tear film cannot recover. And you can imagine that this area here, when that rubs over the surface, that it's uncomfortable for the patients. And so there have been papers, mainly by Kekar, that described that the corneal surface staining was correlated with the amount of fibrosis just from mechanical friction, often in those patients. And they often need scleral contact lenses to avoid the contact of the eyelid with the eye. Unfortunately, once you have the scar tissue, it's irreversible. And it's, it becomes an issue because patients lose a lot of function of the conjunctiva. So I mentioned goblet cells a couple of times, and they are not only important for producing mucin to the tear film, but they also have emerged as an important component of the ocular surface tolerance. So they produce TGF-beta, and that suppresses cytokine production and unnecessary antigen-presenting cell activation. So the meibomian gland involvement in ocular GVHD is important as well, because the lipid layer is important for the tear film. This is a normal patient with, I'm going to try and show you. The meibomian gland openings are open, but in a patient with chronic graft versus host disease, you can see it's thickened, the lid margin, and every opening is surrounded by vessels. There's a lot of inflammation, and patients then are unable to release the lipid, and it becomes more like a toothpaste. And so at this stage, it can be helpful to do lid hygiene and massage that we instruct the patients to do to improve as much as possible the tear film quality. There's also, Demodex blepharitis, which can occur in patients with ocular graft versus host disease, and they are at the base of the lashes. And here you see we plucked one eyelash and sent it to the lab, and you can see the Demodex still here. And so it doesn't create ocular GVHD, but it can aggravate the blepharitis. And so it can be treated with tea tree oil scrubs. And so anything that we can do to reduce the inflammation is helpful in these patients. All right. We measure the quality of the tear film with tear breakup time. That's one of the parameters in many studies. And so on that, as you know from what I've told you so far, depends on the lipid layer, the mucin layer, and the aqueous tears. And so we measure it in seconds. After a blink, we have the patient not blink, and the tear film should cover the eye for 10 seconds. If it's less than 10 seconds, it's considered reduced. And finally, the corneal involvement in ocular GVHD, is characterized by dryness and punctate fluorescein staining that I don't know if you can see it with the light beaming against it. But in addition to punctate staining, patients can also have more severe involvement and sloughing off of the epithelium, and in even corneal perforations and corneal melts, which are very hard to manage once it gets to that stage. So they need to be assessed early and treated aggressively. If you look at this image from Dr. Knopp's paper, you can see, the lid, the inside of the lid that I showed you on that patient that was so inflamed. When the eye is closed, it is in close contact with the cornea. And that is why we see this diffuse staining pattern of toxicity on the cornea. I think it's because the cornea is in close contact with that inflamed conjunctiva. And so we measure the cornea based on how many spots we see after applying 1% fluorescein to the surface. And here we used in this study the Oxford system, and we go by the amount of dots we see. There's other staining systems that can be used for clinical trials. but in this particular one, we use the Oxford system. So this was a brief tour of the ocular surface in ocular GVHD and the involved cells and factors involved. As you can hopefully see, they're all interconnected, and loss of function leads to chronic inflammation and significant reduction of the protective factors of the tear film. So I don't have time to go into the current therapies for dry eye disease and ocular GVHD, but I'm happy to answer questions later. Instead, I wanted to mention some investigational therapies for ocular GVHD that are out there. I mentioned Dr. Jane's study with the DNase drops, and that improved corneal staining and symptoms. Another study that I looked at was also from Dr. Jane's group, where he looked at topical pulled human immunoglobulin drops in dry eye disease versus placebo twice daily for 8 weeks. And he found significant improvement in symptoms and by about 50%, and also corneal staining was reduced. And one other study that was recently completed was a prospective multi-center trial where they used pooled human apheresis products from healthy donors to make fibrogen-depleted human platelet lysate drops. And the reason why they use those is because there are more growth factors in those drops compared to autologous serum drops. And there was no significant improvement in Schirmer's test or fluorescein staining in the groups, but the symptoms improved. And finally, it has been circulating that there would be a phase 3 trial on brimonidine drops for ocular GVHD, but unfortunately the primary endpoint was not met and the trial was terminated. So currently, treatment with Janus kinase inhibitors or short JAK inhibitors is being investigated also for eye disease. And there are not many publications related to eye disease with the use of JAK inhibitors. There's one in 2012 where tofacitinib was used for dry eye disease, and they used different concentrations of topical tofacitinib for 8 weeks and compared it to cyclosporin drops, also known as Restasis. And the primary endpoint was the proportion of responders whose Schirmer's test were 10 millimeters or more. And unfortunately, the Schirmer's test did not improve significantly, but corneal staining was improved. Sorry, let me go here to this. And then another trial was Dr. Dana's group from Mass Pioneer did a randomized trial of a topical JAK1/3 inhibitor and spleen tyrosine kinase, and it treated patients for 12 weeks, and he found that the corneal staining scores were improved. There was no improvement in Schirmer's test, but the symptoms were improved as well. And then there was one retrospective study where patients were treated with ruxolitinib for chronic systemic GVHD, and they found after 6 months, when they did a retrospective review, that they had improved ocular GVHD scores. And one last study, just a small case report where ruxolitinib patients, they were on ruxolitinib systemically, and Dr. Sunshine's group found improvement in symptoms in patients, but no corneal staining improvement. And so now I finally come to our study. This study was led by Dr. Pavletic on the effect of baricitinib in chronic systemic GVHD, and it started 3 years before I arrived at NIH and ended last year. So I want to point out that the study was conducted during the pandemic as well. And so sometimes there are some data points missing at least on the ocular side. So we had to do eye exams on patients at baseline and primary endpoint and end of study. And so I took that opportunity to look at the eye findings on these patients. So out of the 24 patients, 18 had chronic ocular GVHD, and we assessed those parameters that I mentioned through the talk. This is just a abbreviated baseline of the demographics of the patients, but you can see that all of them had a severe score of GVHD, and almost all patients were on ocular medications, which did not change after enrollment, but 17% were on steroids and 17% were on cyclosporine drops. So when we first assessed for conjunctival fibrosis, we noticed that 7 patients, or 39%, had pre-existing conjunctival fibrosis. We also saw that, when we looked at the groups, there was a significant decrease in the NIH ocular GVHD score compared to baseline, but there was no change between the fibrosis and no fibrosis group on that. And here, if you look at all the patients with ocular GVHD, we saw that there was some tendency for decrease in the ocular staining and an increase in Schirmer's test, and also an improvement in tear breakup time, but this was not significant, statistically significant, although clinically it may be significant. And so then we decided to look at the patients without conjunctival fibrosis, which, as you know, have more reserve and may be able to respond more to anti-inflammatory therapy. And there we saw that corneal staining was significantly reduced, almost by 2 grades. And there was an increase in Schirmer's test over time at endpoint and then at end of study, and as well as the tear break time seemed to improve. But again, because of the small numbers and some missing data points, it's not statistically significant. When we looked at the patients with pre-existing conjunctival fibrosis, we see that there was no improvement in, there was a slight improvement in Oxford staining, corneal staining, but nothing in the Schirmer's test or tear breakup time. In terms of adverse events, we had not many. We had 2 patients with conjunctival papilloma. I outlined it here in the blue line, and they were asymptomatic and self-limited, and without, they resolved after some time. Bacterial conjunctivitis, and 1 patient had 2 incidences of bacterial conjunctivitis that were treated with topical antibiotic drops without problems and resolved within 1 week. So this is a small study. And we don't have significant findings really to report, other than that NIH ocular GVHD score improved. But we did see some clinical improvement in patients who didn't have pre-existing fibrosis. So what is my discussion is that I think the ocular scar tissue, the conjunctival scar tissue, did contribute to the ocular staining pattern, and there is a possibility that patients who have fibrosis, even with anti-inflammatory therapy, cannot recover tear function, goblet cell function, and lipid function because of damage that was done. But we need further studies to determine whether this is the case. So in conclusion, I think that patients without pre-existing fibrosis may benefit from oral baricitinib to reduce ocular surface inflammation and improve function. And when we enroll patients in clinical trials, it may be useful to determine whether they do have a fibrosis or not, because as we know, just a mechanical fraction and the loss of conjunctival function can affect outcomes. Thank you so much. I'll take any questions.
That was really terrific. And thank you so much for educating us on the complexities of the anatomy of the ocular surface. There's a lot more than, quote, meets the eye here. And I think as clinicians, we sometimes lose sight of that. And I also would say, sorry, this is terrible. But I would also say, I think one of the most impactful slides was one of the first where you say, how this impacts the patient, not just about can they see okay, it impacts so many facets of their lives. And I think we lose, I think as providers, we can not pay enough attention to that. It also seems that, as is the case with graft versus host disease, whether acute or chronic, the longer you wait, the harder it is to kind of bring some of these things back and maybe treat these people successfully. What are your recommendations for following patients from an ocular perspective post BMT, even without graft versus host disease, and once they develop chronic GVHD? What would your suggestion be to clinicians to say, you know, we really need to follow this? Because if you wait too long, and again, someone's developed fibrosis, for example, certainly they're going to have some signs and symptoms of disease, but if you're waiting too long, the ability to kind of remedy this problem goes away. So what would your suggestions be there?
I think thank you so much. My suggestion would be, let's say you have an asymptomatic patient and you see them 3 months after transplant. During that period where you are concerned that graft versus host disease can develop, during that time, I would recommend seeing them more frequently than yearly, and to make sure that there is nothing developing, because sometimes patients just think, oh, it's just a dryness because of the weather and so forth, but it could be early, inflammation. So during that time, ideally, if you could see the patient every 3 months and then taper out if you don't see anything. But a major part of it, what I do at NIH is educate the patient and make them aware that if they feel the eyes are dry or the vision is blurry, to not, they have so many things going on and they don't want another doctor visit just to look at their blurry vision, to just let them know we need to treat this early. If you see a patient with early inflammation, you can probably with steroid drops turn things around. If they don't come in by the time things are burned out, it's much more difficult to recover function. So education of the patients, don't think you are getting on my nerves, just tell the team, make sure that if you feel there is a difference in foreign body sensation, a difference in dryness, come in and we'll evaluate you.
Excellent. Other questions?
Thank you very much for the great presentation. 3 quick questions. Do you see this potentially as being used prophylactically?
This is a great question. Steve, you want to using Baricitinib prophylactically. I think, it's too early, but down the line, my opinion is that we have to consider ocular GVHD not as a topical treatment area, but we need to treat it systemically as well. And we do that when it's grade 4 ocular GVHD. We increase steroids systemically, and we work with the team to increase immunosuppression. But I feel ocular GVHD has always been neglected a little bit. Oh yeah, it's just dry eye, but it is not. There's more behind it. And I believe it has to have a systemic treatment has a role in it, such as, in uveitis as well,
Right. And during the trials, I don't know whether you looked for this, but did you see any improvement in systemic GVHD in any of the other organs?
So that is up to, I didn't look at the systemic data. Steve, do you want to comment on it? I think we are, yeah. So Dr. Pavletic will answer that question.
Yeah, that was presented, I think, at the tandem meetings. There's an abstract, and now the study is completed. But yeah, there is a substantial systemic effect. It's a JAK1/2 inhibitor in a very difficult population of patients. You know, we started this study because it has theoretical advantages, you know, over existing JAK inhibitors in terms of GVHD, GVL balance, and side effects profile. So one of the things is that we don't see anemia or thrombocytopenia. We do see some neutropenia, so it's a little bit different. Yeah, so it has systemic. Yeah.
Other questions?
That was really helpful. Thank you so much. I just have two questions. One is if we want to stratify between patients who have pre-existing fibrosis or not in terms of our treatment decisions, I know that I'm not good at the ocular exam. If we want to send someone to an ophthalmologist who may not be as experienced with GVHD, what would we ask them specifically to look for in order to determine if they have this pre-existing fibrosis or not?
So as you know, as you saw, the upper palpebral conjunctiva is the main affected site in the eye. So I would tell to make sure that they flip the eyelid and look. And once you do, you see it. It's a white band. You can't miss it. So that will be the first one. And if you pull down the lower lid, you will also see fibrosis if you look carefully. But most obvious, it's under the upper lid most of the time. Okay. And it's present in about 40%. So it might be important too. I think specifically for ophthalmic studies, we should differentiate, you know, because it will, I think, skew the data towards no function when there is really, there might be an improvement with the treatment.
And my other question is, considering the impact of ocular GVHD on quality of life, are in any of the studies that you presented, were patient-reported outcomes included that you know of, like there's, you know, symptom scores, things like that?
Yes, in all them, they looked at symptoms. We use, you know, the ocular surface index score mostly. And I think I mentioned it that in most of them, the symptoms were improved. And specifically in Dr. Jane's study on the DNase drops, there was a significant improvement of basically 50% improvement in ocular symptoms.
Thank you.
And Dr. Cook, I have a question from Zoom virtually. Can you comment on the possible role of, I get this word wrong, spiral non-lactone eye drops for ocular GVHD?
No, I don't have experience with it. I know it's not FDA approved, and so it becomes difficult to obtain those, but I don't have any experience with it.
Hi. I think it was 2-3 years ago, there was a presentation at ASGCT about using like progesterone preparation on the forehead. Any advances in that, or is it just now?
No, that's it's still being, I think it's a phase 2 trial, and the preliminary results are good. I didn't include it because it's not really an eye treatment, but I'm very curious. I think it would be a great additional tool if we could use that. So what he's talking about, progesterone ointment on the forehead improved ocular symptoms in patients with ocular GVHD. And that is still an ongoing trial.
Any other questions? Well, that then, oh, Steve. Steps in.
One quick question. Actually, I would like, I was supposed to acknowledge as well Dr. Noah Holtzman, who was the first author on that abstract that was presented in the Baricitinib study. But just these patients have, they had a ophthalmology exam because it was a part of the systematic approach in the clinical trial. It was not because they necessarily had eye symptoms. I should know it. I don't really. Do you know, out of those patients that didn't have fibrosis, how many were really symptomatic?
Of how many patients out of who did not?
Yeah, who did not have fibrosis.
So when they presented to the eye clinic, most of them complained of dry eye symptoms.
Mhm. Mhm.
Just you know,
Okay.
the ones with fibrosis had more severe
Mm-hmm.
ocular scores, but
Mhm.
they all, you know, they all complained of eye symptoms.
And do we know in natural history, do these patients necessarily, most of them progress into fibrosis, or we don't know?
No, not at. I mean, I've only been at I have only seen your patients for 4 years, but we have not noted that patients had developed fibrosis in that time frame.
Mhm.
You know, while I've been there. You know, but I do still think even if you don't see the subtarsal fibrosis in those patients, they still lose function if there is chronic inflammation going on. The most of the time when they have fibrosis is when they develop those membranes, the membranous conjunctivitis during exacerbations. And we have seen patients who come in where the bulbar conjunctiva looks relatively quiet, and they just say, oh, it's a little more dry, but then you pull down the eyelid and you see the membranes. So they can develop these membranes. They don't necessarily are terribly symptomatic. And we have seen patients who came in and didn't have fibrosis and then came back and had fibrosis, but these were not the natural GVHD patients. You know, there were different other protocols.
Terrific. Oh, one more question, Betty. You know, geez, we're just backed up on lunch here, but
Hi, this is great. So we know in chronic GVHD, any organ with fibrotic type of manifestations is really challenging to treat. Are there things that you use in particular when you see fibrosis, ocular fibrosis, that you find might be helpful in any way?
So once you have fibrosis, and then so you'll have the mechanical friction and that component that will cause discomfort. At that point, I prescribe scleral lenses to patients, and I really, you know, I'm a proponent of using that earlier than later, because I feel they are affordable nowadays. They are not as expensive as they used to be, and the quality of life of patients really improves with a good scleral lens fit. So I actually push patients earlier on to obtain those because I feel it will the inflammation will always be there, but that will improve the comfort and vision as well.
all joking aside, this discussion is as good and as important as anything else. So we will certainly.
When you move to the lenses, are you seeing any kind of problems with those in the patients?
I'm sorry, I didn't understand the first part of your talk.
When you prescribe the lenses,
Mhm.
are you seeing any adverse problems in those patients?
No, so you have to have a good fit with those lenses, and if you have scar tissue on the bulbar conjunctiva, it could cause problems, but there's ways to shave off that area. So there is a more complex fit that is needed, but I have not seen problems or infections. I've seen actually very good results. And I think part of it is because the scleral lens is filled with fluid, with preservative-free saline, and applied on the eye. And so the cornea is bathed in that saline, and also the tear film, which is toxic, cannot get to the cornea. So that lets the cornea recover. So I really think it doesn't treat the underlying inflammation, but it kind of creates a barrier between the toxic tear film or the cells and the ocular structures.
Dr. Magone, thank you again for a terrific presentation, great answers to the questions.